welcome to our first Health and Care Hangout. I'm really excited about this one. I'll introduce myself quickly and then I'll pass it on to the rest of the crowd for a casual, difficult conversation on systemic racism.
Roxanne, you're on mute.
I can hear you, Roxanne.
I can't.
I can hear you too.
Well, is this better?
Still fine.
Good. So welcome everyone. We made it. First Health and Care Hangout about systemic racism in healthcare. I'm really excited to have you all on the line with us today. I'll just introduce myself really quickly and then maybe...
Can't hear. I can't hear.
Does no one hear me?
I can hear you.
No, we hear you, but I think Julie has a... We can hear Julie, but Julie can't hear you.
Can anyone hear me?
We can
hear you, Julie.
But I can't hear you.
I'll give you a minute, Julie, to sort this out, and then we can start with the rest of the crowd in terms of introduction. We announced it as casual and friendly, so this is a good introduction for this. So I'm Roxanne. I have set up Qassandra with the hope to support people and patients in particular get around the power imbalance between doctor and patients. And so this topic of racism means a lot to me, as racism is yet another power imbalance, and the two of them at least compound, if not amplify each other further. Maybe I'll hand over to you, David, as a co-host for today and lead of WHIS EU.
Thank you, Roxanne. So, hi everyone, David. I myself am the chair of WHIS Ireland and most recently WHIS Europe as well. What we're doing is local chapters, as with WHIS London, where we're looking to where we can to integrate people from public sector, corporate and non-profit initiatives, charities, to really build that bridge to enable social prescribing at a national level. So we're working to really build that community noise, that community presence to drive that forward. On that note, Matt, I'll pass over to you.
Yes. Hi, everyone. It's a pleasure to be here. So my name is Matt Sisto, and I'm Director of Patient Experience at a NHS provider trust in the east of England, and we're a lead provider for community mental health services. And I'm here to talk about something that I'm really passionate about, and that's disadvantage, inequality and inequity, and the patient care race equality framework, which is one of many tools that the NHS has co-designed to tackle inequality in healthcare.
Thank you. Kautar, do you want to go ahead and introduce yourself?
Yes, so I'm Kautar Benmoumen. I'm a clinical psychologist in France, and I work in l'association, je te laisserai Roxane dire le nom, please, l'Association pour le soin queer et féministe.
The Association for Queer and Feminist Care.
Since 2022, and I'm a formatrice in discrimination and intercultural point in the healthcare.
Okay, so trainer in intercultural in healthcare. Thank you so much for being with us here today. Julie,
thank you for having me.
Are you all ready to go? Nope, you can't hear us. Do you want to try again? Okay. Maybe I explain a little bit what we're so excited to have you together today, Kautar and Matt. I think Qatar, you developed with the association you mentioned, a barometer of racism violence, a scale to understand people's experience. And you, Matt, you work a lot in policies and institutions. I felt this was a little bit taking the same problem, but from both ends. One that is for Qatar resting on individual initiative that organizes itself as a collective. And for you, Matt, starting from policy and institution. And that's what we wanted to bring together. In the middle of all this, of course, there are patients. And we had Keisha Green, who has, sorry, she's a professional. She supports women who are going through domestic abuse, among plenty of other things she does. She has a forest school and a lot of things. She wanted to join us today to share her experience. Unfortunately, she could not make the time, so I had a session with her privately, and she's trusting me to relay her voice. And I wanted maybe to open up by sharing her story, and then get your feedback on, is this really just one story in isolation, or in which way is that representative of what systemic racism in healthcare can look like and do to patients? Yeah. So imagine I'm Keisha, and I'll be reading as well because I want to do justice to her words. So 20 years ago, Keisha was a teen mother. So she was pregnant at 16. She's of Caribbean descent. And during her care, she felt very quickly that she was treated differently, spoken to differently from other mothers that she could see in the same waiting room as her. And at the time, she was, is it because of my age? Is it because of my skin? And she didn't know exactly what she was being judged on, really. But in any case, it was not her ability to become a mother. It was something beyond that, if I can. Her midwife, who is Black, she remembers distinctly a moment where the midwife asked her, where are your parents from? And when Keisha said, I'm of Caribbean descent, she felt she gave the wrong answer to the Black midwife, who was from the African continent. On top of that, Keisha was also a victim of domestic abuse coming from the father of her child, who has been aggressive towards the midwife. And so the midwife used that as an opportunity to just pretty much give up on Keisha altogether and send her back to the GP saying, I can't follow you anymore. I don't want you in my care. The GP will do it for you. And Keisha remembers feeling quite abandoned, that if that was a situation that the midwife didn't want for herself, she seemed to have no concern for the 16-year-old who was living that every day at home. And then on top of that, the said GP was on maternity leave. So effectively, Keisha was left to her own devices for the entire third trimester leading up to the birth. Again, at the birth, she's in labor, she's in the waiting room, and she can see that other mothers, other white mothers are being seen quicker than her. She says she was left unattended for 5 to 6 hours after her waters had already broken. By the time they came into the room, they just immediately rushed her to an emergency C-section. After that, and with not much more explanation, as she was trying to feed her baby, she kept saying something is wrong. My baby's not feeding, something's wrong with my baby. And her words were, I had to insist and demand for her to be seen by a doctor. Eventually, the baby was seen by a doctor, and they realized then that the baby was in a very critical state, rushed to a critical care unit in a different hospital. And later on, Keisha understood that her baby was in risk of dying in that moment. I'll post here in her story. She also mentioned before in the delivery that her pain was never acknowledged. She was only told to breathe through it, and never even paracetamol was offered to her. So that's setting the scene, because then Keisha would go on to try and fight and respond to this abuse in many different things. And that's something that I want to do justice on. But I wanted to pose here already in terms of, is this what systemic racism can look like? Or is that just a one story in isolation? Of course, I'm priming you a bit, but it's because we've worked on that. So I don't know which one of you wants to take that one on. Matt, do you want to respond something to that? Is that a familiar story in a way?
Yeah, it is. Sadly, it is. And I think it's multi-layered in terms of how complex the issue is. And if we look at the National Embrace report in the UK, it looked at the disparities in care for Black women who go through maternity services. And for example, they're 2 to 3 times more likely to die in childbirth. So that really speaks to that story, and it's not an isolated incident. And what I would say is, in my experience, it's not necessarily just about racism and how people view racism. It's about those biases that people have around things like Black women have a higher pain threshold, or a lower pain threshold, or however people perceive different cultures, and then respond in that way, which kind of compounds these issues and result in really poor experience, access and outcomes for people.
Yeah.
And Julie, I think you hear us and we hear you, so maybe we take the opportunity for you to introduce yourself and maybe give you the opportunity to react on that.
I didn't hear most of it because I was trying to get in. But anyway, my name is Julie Jaye Charles. I am part of WHIS, the World Health Innovation Summit. I am WHIS London, and I'm also the CEO and founder of Start Change, which is a social justice organisation. I think that what I did hear with regards to Keisha, like Matt said, one of the things that I really want to pick up on that he said, which is really important, is this thing about Black women having this higher pain threshold. And that's very, very concerning, because she wasn't just a woman, she was a young woman. She was a young woman. And so where does that come in? She was a child, really. And so I think that a lot can be said about racism in healthcare, but I think sometimes we've got to face up to the fact that racism can equal negligence, and that's not often spoken about. And I think that that's important, that we recognise negligence when it is there.
How do you, and maybe I'm talking to you here, Matt, as you've worked a lot with the NHS as well. If we talked about negligence, how do you put your finger on it from an institutional point of view, and how do you address that? Because of course it's health care, it's not health negligence, so something is completely wrong here. But then how do you address it? And I felt there will always be the answer of like, oh, but if you're trying to address this problem, then you're taking away from another problem that also needs addressing. So what would be your response?
Yeah, and Julie's absolutely right. We talk about something called intersectionality, where there's a whole range of factors that overlay one another and compound the issue. And Julie talks about the Keisha's story, and particularly around age, gender, ethnicity. All of these are factors that compound someone's bias and response. But bias isn't always a bad thing in terms of our human behavior, because it allows us to respond automatically and activate our system one thinking, but we also need to be aware of these biases, or we can check and challenge it and say, actually, I'm responding this in an automatic way, and I'm using a bias which may be totally unfounded. And so, you know, in that case, I'm sure there are multiple factors which result in really poor experience and outcome. And the way that we address that is by creating opportunity for people to check and challenge those biases, be really aware of bias. And racism is a difficult concept for people to grapple with. And I myself have been on this journey, right? I remember a few years ago when I started just exploring and working with inequity and inequality, I never identified myself as racist. And it took me some time to understand privilege. And in the UK, a few years back, there was a real focus on white men having all the privilege. And it felt really alien to me because I come from a single parent family. I grew up in a rough area. I had a really difficult time at school, and there were many times where I was failed by the system. So I really grappled with this idea of privilege. But then I come to understand disadvantage, and what I really recognise is that, yeah, I may not have had privilege in my mind, how I view privilege, but I also didn't have disadvantage that comes with being black, for example. And I think that was a real turning point for me to understand what it means in terms of systemic racism and judgment. And I've seen it myself when I've worked in inpatient services and mental health. I have seen a white man shouting and seeming aggressive being treated differently to a black man shouting and seeming aggressive. And if we look at the data, actually, you know, black people are far more likely to be detained. They're far more likely to be restrained, and they're far more likely to come into mental health inpatient services through the criminal justice system, which speaks to coercive and controlling behaviours. So the way that we, I think, challenge and overcome this is through education, is through challenging and addressing biases and using the data to really tell a story, because that's super important. Because once you identify the data, once you've got it out there and you say, look, black people are 10 times more likely to be detained, we've got a problem here, particularly when you compare that to your population demographic.
Just for me to understand here, you talked about biases, but those are something that every individual carries within themselves, right? Is there something out there, like in terms of, can you be all, you know, acknowledging your bias and so on, and still the system is built in such a way that there will be a difference in treatment, or is really the problem just within each and all of ourselves?
I know Julie probably has something to say, but so I will say one thing, and then I'd love to hand over to my colleague. I think the starting point is acknowledging that we all have biases, however uncomfortable that is. Okay, and often it's unconscious, you know, and that could be, you get on a bus and you see a young person with a hood up and you feel all of a sudden threatened, and you may sit 2 or 3 seats away from them. These are the sorts of biases that actually come quite natural to humans, because it's that fight or flight safety response. But when you recognize and check and challenge that and say, actually, where is this bias coming from? That's the starting point, recognizing it, challenging it, and thinking about how that impacts your behavior.
Yeah. I think that, yeah, again, I agree with Matthew. I think that when it comes to biases, that's quite a big area to unpick, because all of us have biases in very different areas. Someone's at the front door. Would you believe it? It's okay, I've got someone that can answer that. But to unpick it, I kind of look at, let's talk about the NHS, for instance, healthcare. And the NHS has been going now for over 70 years. And the NHS went from a place of developing because of war and poverty in communities that couldn't pay for care. Now, there was no inequality when the NHS started, and then we had black nurses come from the West Indies, the Caribbean, in the 50s and 60s to actually make the NHS what it is or what it was back then. Things have changed. There's been a gap of where something's gone terribly wrong, because when you had those nurses that came from abroad or trained here, the racism that we have now wasn't real then. It didn't happen. But there's a gap, like I said, in the NHS, and I think that is where, when we talk about biases, I think that we need to hold our hands up, all of us that work within the NHS, and say, okay, then I'm not doing something right. I'm experiencing something. I'm not doing it right, and I need to be honest about where I'm at. But it's not happening, and it's causing things to crush. And that's my honesty.
I hear what you're saying, Julie, in terms of something's got to change, and we're not really sure where it needs to change from. If it needs to change based on every single person, that feels both very hard to reach. How do we reach every single person that is part of the system? And also a bit daunting. But I'd like to hear your point of view, Kauta. And maybe before hearing you, I just want to share another part of Keisha's story, because I think it's very telling in terms of what are the resources available to tackle all of this. So after Keisha went through all of that ordeal with that first child, so she's by then 17, she's a young mom, and yet she decided, her words again, nobody deserves to be treated like that. Everybody deserves to be treated with care and kindness. And so her response when she had that realization was that she would become a midwife, and she would take it on herself to make sure nobody under her watch is ever treated that way. And however, in the studies, she said that even though I had my nursing badge now, it was still the same. I still had to push for my voice to be heard, including with colleagues, to the point that eventually she would never realize that hope, and she would quit midwifery altogether to go into education, where she found another set of challenges. But I think that says a lot in terms of how ingrained racism is and how hard it is to tackle if the source of it is kind of a bit everywhere, but also nowhere. How do you tackle that? I think, Kauta, you've given that a lot of thought, so I'd like to let you react to that.
Yes, regarding that situation, I think that we all agree to say it's not one situation in particular. It's the reflection of years and years of education in every level, for me, in every age, being aware of our biases is something that needs to start in the very young age and be introduced by our parents, our teachers, the group of people that built us as a child, as an adolescent. And for me, in the healthcare, there is some biases who are give in the like a knowledge, like something in France we have, that's what we call Mediterranean syndrome, that Black women and Maghrebian women will always overplay the pain. They are likely to cry out loud, to make a lot of noise, but it's not really pain. It's just the expression of themselves. And that kind of theory is introduced in medical school today. It's something that's reinforced with nurses, with doctors, with obstetrician services, that you don't need to acknowledge the pain of those people because it's like an act. They need to cry, they need to yell, and they're overplaying that. So don't give him too many painkiller, because there is some biases that painkiller is not really for them. They take it and left it for the family so they can give. It's a lot of constriction, that there is a lot of steps. These people are not really honest about their pain, about what they need, about the medical care. And you can find, even if you are from the medical care staff, the kind of stuff that you're gonna reinforce. What struck me in Keisha's story was the first midwife she saw was a Black woman. And we can ask ourselves why another Black woman, even if she's not Caribbean, cannot acknowledge that there is something wrong with how she treated Keisha, how she responded to her pain, her young age, and sometimes we think that they're gonna dress some kind of kindness to someone of our community, even it's a community that's neighbor to us. But no, it was something like Keisha felt it. She said she felt it. She wasn't giving the right answer. And for me, it's something we can observe in the first and second generation immigrant population, that there is the dominant population, white population. I'll always say to immigrants that there is a good immigrant and a bad immigrant. Mm-hmm. And we are so afraid to be rejected, to don't have the same chance than another, that we acknowledge sometimes and we reinforce the stereotypes and prejudice about bad immigrants. I'm not like them. Look at me. I'm the good one. I'm done to do a lot of noises. I can speak a good French. I have education. I have a good job. Everything to reinforce. So you're right. There is a bad immigrant. We for the money, for the healthcare, the free healthcare, and all of this. And it's very uncomfortable. You said, Matt, earlier that you acknowledge some uncomfortable awareness of your own biases. It's more violent for people of immigration to, at some age, have political awareness to see when we play the prejudice. We enforce them because we need to survive. We need to survive in an environment where from the beginning we are in the losing team. Mm. So unconsciously, I think we start by doing some stuff, some reinforcement of the prejudice and the stereotypes that just a survival need to not be rejected, to be accepted for what we are in somehow, because we denied ourselves who really are what we are. Because if we let ourselves be that, we're gonna end in the bad immigration group.
See, sorry, so it's almost like somebody is going to lose, better them than me.
Yeah.
Can I just interject? Because when it came to Keisha, because I know a bit more about the story, the actual experience that she had first and foremost when she was in labour, the experience was from, yes, the bad experience was from a black nurse, midwife, but let's remember that within black there's different cultures, and within black there's different ethnicities, and it wasn't a Caribbean person. And I think that we need to look at how culture, because you're black, it doesn't mean you're all the same. Yeah. And because of culture, there's heavy culture differences between Caribbeans and non-Caribbean black people, let's say African black people and Caribbeans. And often there's a lack of understanding between the two. They clash. And so I think that that's something that needs to be unpicked at some time. Yeah.
I think that's what Qassandra was referring, like rivalries across different communities, because somebody has to lose. So always rather it's their other community that loses. I know I'm quite close to the South Asian community around London, and that Mediterranean syndrome that exists in France is called the Begum syndrome in the UK, and the Begum is after a name that is very common, for instance, in Bangladesh. So it's exactly that same concept, but it's just who are we going to slap that label onto, and who are we going to take down with this? Julie and Matt, I open to you because I feel we've talked a lot about how big the issue is. It's not only white people, it's literally everybody who needs to go through that painful process of acknowledging your own biases. And once you've acknowledged it, you've not even done half of the work, because you still need to correct and understand what else you need to do instead of going with your gut by then. But then we've also said it's also baked into the system through education and our doctors and nurses training themselves. And not like you might enjoy to share a little bit the example of Compass as a co-creation solution to tackle that from the entry point. Over to any of you. I need a brave one.
Yeah, I'll start, Julie, and then if you chip in, and we'll collaborate on the response. So I mentioned briefly the Patient Care Race Equality Framework, which is a legislative policy change. I think sometimes policy changes take a long time to embed and have an impact, but we're already seeing a much greater insight into the differences in experience, access and outcomes of care in the National Health Service, particularly in mental health services for people from racialised communities. And that really is a turning point, I think, because we're having that conversation. We've been forced to have that conversation by the Care Quality Commission, and they will be asking providers about what are they doing about race equality in the provision of care. And I think what's interesting, and listening to Kotal about about the health service in France is particularly mental health services. In the last few years, we've seen such a significant influx of international nurses, and our international colleagues, on the most part, in mental health services come from African nations. And so it really isn't about white and versus black, or it is so ingrained in different cultural beliefs and stigmatization of views. And if you look at mental health as well, you've got the whole stigmatization that comes with different mental health diagnoses, and we could get into a whole can of worms if we start talking about personality disorders, because they are often on the receiving end of real discrimination. And then if you overlay that with ethnicity, gender and age, it just becomes really complex. But I think you're right, Roxanne, in the concerns that it is such a big issue. And I feel at times, just talking about it, terrified. Will we make any headway? You know, I could spend 20 years working in this space and look back and think, God, I actually had a very small impact. But I think it's important that we get started, we start somewhere, and then we learn from there. And I think that initiatives like Compass and partnerships with NHS organisations and organisations like Start Change, that's where the real work will happen. That's what we need to do, because there's lots of distrust and mistrust across communities, and we need to change that, and we need to change the way that we empower people to co-create, co-design their services so that they are culturally competent, and we're picking up issues much earlier, but many of them are societal. And so, Julie, do you want to come in on Compass?
Yeah, well, Compass is a program that has been rubber stamped really by EPOT, where Matt has been working with me and some of the people that are part of Compass to develop structures whereby black males, black men, black males within the systems, whether that's the mental health system, the criminal justice system, or the system within the criminal justice system, are able to have support when they come out of any system, the prison system, mental health system, the homelessness, and just to be able to have somebody to support them on their journey back into society. Now, that journey into society could mean linking back up with family that they've lost, no longer connected with, if that's what they wish and if that's what the family wish. It could be that they're homeless. They've come out of prison, they're homeless, they haven't got a GP, they haven't got this, they haven't got that. Now, Compass works in an intersectional manner, like Matthew said earlier. It is about pulling together the intersects of one person and tying that up into community. So if somebody is a male and they're a black male, they have mental health distress, they could possibly be disabled, or they could be gay. All of these things should be looked at holistically, and they should be looked at intersectionally. Now, Compass is a program that does all of those things, and it's being rolled out in Essex under my watch and Matt's watch, and that of NHS England and the Integrated Care Boards. And we're really pleased that we're beginning to open up a gateway to show that there are avenues that you can support people. Not all black men are thieves. Not all black men haven't learnt their lesson. Not all black men are rapists. Not all black men have knives. And we need to understand that and to put something in place that actually suits them first and foremost. Yeah.
you've talked here you've talked in the beginning here about co-creation, and I'd like to understand how that works and what's the first step if someone out there is saying like, okay, I see the problem, I see I don't have the experience and the knowledge, and I know some stuff on how the system works, but clearly the success is on co-creation. How do you go at it?
How do you do co-creation and co-production?
Yeah.
It's about bringing more than one person together to actually have conversations about what they believe in and what they think is a way that can support them and support their neighbour and support their uncle and their aunties. And it's a voice and it's a viewpoint that can be pulled together by more than one person in conversation and actually become policy, a policy from a grassroots level. And I think that's what we miss in this country, in the UK, very much so. The UK is a racist country, and I don't think we should hide from that. And by co-creating and doing things differently, it doesn't mean the country's going to collapse. It's going to enhance the way we are with one another and how services can be improved.
I love what you're saying, Julie, and I'm smiling because I remember when I first met Kauta and we discussed, there was, correct me if I'm wrong, Kauta, but there is that impression in France that there is no racism in the UK, that this has already been all sorted out. And Kauta, that you were even surprised when we're having that session for the UK. Do you want to speak to that a little bit?
Yes, indeed, it was a bit of surprise, but maybe because I think it's a fantasy we created around among Muslim women, where the hijab, that they can be more free, more respected in England. So for the Muslim community, there is some kind of appeal to England to be respected, to be acknowledged in the identity, the Muslim identity that you don't have in France. In France, it's very so violent, so dismissive that at the end you need to, I think, create something that's just 2 hours flight, and I will be better. And so when we first talked, it was, but first it was a bit coherence that yes, there is a racism in every country. First, because I know that in Morocco, negrophobia is very, very present. I'm a Moroccan woman. Yes, I was born and I lived in France, but I see with myself and I hear how Moroccan in my father's family talked about Black women and Black men. And I was shocked to see the same constriction, the same stereotypes, the same discrimination. That was, they're going to take our job, they come to take our place, and I was shocked by that. And when we first talked, I said, well, it makes sense that in England too, even it's for me, it's like an Eldorado for Muslim women, there is racism. In maybe some things that I can understand on knowledge because it's not my everyday life. And in that, I think it's very important, like Julie said, that we can bring people together to exchange our reality, our experience, our point of view, even our comfort experience when I talked earlier about the awareness when we became political and we go to see what we did as immigrants to reinforce stereotypes and biases, it's not a comfortable place. It's really not, because we feel in our blood, in our body, that damn, I did that, I say that, I reinforce that thing that was violent to my parents, to my grandparents, to my brothers, sisters, to my neighbor, to some people is not of my community, but I said yes. Black women yell too loud, screams. It's uncomfortable. It's shameful sometimes. So it's very, very difficult to have the humility to say, yes, I did something really wrong at some part of my life, because I was unconsciously in a survival step to try to succeed in somehow.
Yeah.
You know, as a Black woman, I'm often told I've got a loud voice, but I love it. You know, sod the world. I love
You're
it.
right.
And whoever finds it difficult that Julie Jaye has the loudest voice, and it doesn't mean I'm aggressive. Very, very, you know, people that know me would know that's not me. It's just the way I am, and that's it. You know, but I think we should hear from David and Matt again, Roxanne.
Yeah, absolutely. Yeah, go ahead.
Yeah, I mean, I would love to chime in, because there's been more than several fantastic points really highlighted today. But I think first and foremost, bias, and in particular unconscious bias, is everywhere in the world. Because what's coming to my mind is being Scottish, as you can maybe tell. So being Scottish, being British, but having lived in the Republic of Ireland, Southern Ireland, for 2/3 of my life, which people in Ireland are like, wow, you didn't move here yesterday. I mean, I am all too aware of unconscious bias. So whether it is Caribbean Black, African Black, or Scots, Irish, English, unconscious bias is everywhere, regardless of skin color, ethnicity, so on and so forth. It's a human condition, unfortunately. But I think, Julie, you highlighted a particularly good point. Not just for the NHS, but every healthcare system.
Yeah.
Heavily the NHS that shaped healthcare systems globally. When it was first created back post World War II, it was created with good intentions. It was created not with bias. And I mean, that's still there today. And I mean, it was quite a few years ago now, but I was working with an IT provider. We worked with the with the NHS to create an application to go through the maternity process with the NHS, to have more open communications, make it smoother, to understand the health benefits that are really there, help people provide feedback and stuff like that. So, I mean, the good intentions behind the NHS and other healthcare systems are there. It's just it's buried in so much bureaucracy, paperwork, and so many systems that I think it comes back to the starting point again, Julie, where the most important thing is getting that policy in there from the ground up, so that from the top down we can have the governance that's needed, but we can have the training from the ground up that's needed to meet that policy met in the middle. So I think there's been many fantastic points around all of this and more. And what you're doing with Compass in particular really sounds like it's going down the right road there.
Thank you. Thank you. Matt?
Yeah, I'm really passionate about the NHS, and I've been on a real journey, and I'm so privileged to work in the National Health Service in the UK. I genuinely believe that. And absolutely, it's not perfect. If we think back, and Julie, I'm going to kind of just throw in a challenging perspective. We think back when the NHS was first introduced back in 1948, you know, there was inequity in healthcare.
Yeah.
The health services were based on the people that could afford it, you know.
Yeah.
And actually, by introducing healthcare, we created access for all. We introduced hospitals, GPs, and it radically changed the health of our society. And that's introduced its own challenges, right? Because people are living for longer and have much more complex health needs, and that in itself creates strain in the system. But what's important to flag is that our population has changed. Our population needs have changed. And as such, we need to really challenge our thinking about what it means to provide an equitable healthcare service, and not one based on equality. So everybody gets the same equal access. It's about equity, that people get the services, access to the services they need in the right way. And for me, that comes down to really understanding the population, without judgment, without bias, without stigma. And we'll come back to that conversation about co-production. The first thing you start with is a conversation and deeply listening without judgment, because fundamental to co-production is relationships. Julie and I have a great working relationship. It's taken time for us to get to that point, but that has to be the founding block. And for me, to say, I'm really privileged. I work in a very senior role in the National Health Service, and I don't take that lightly in terms of my responsibility and accountability. But I also recognise that I need to cede power and share my power, my resources, to empower others to be able to make change happen. And that's a real shift in terms of the medical model that kind of that permeates any healthcare system in terms of how it's structured and where the power sits. And I think, come back to your point, David, about unconscious bias, that does require a level of emotional intelligence that we need to support people with to really get to that point, to check and challenge their own unconscious bias in a psychologically safe way.
Oh, sorry, David. I wanted to hand over to Qassandra then, because she was part of a team who created a tool where the goal is specifically to help people acknowledge their bias, but I think that can also really help patients make their voice heard, as Keisha noted, but also put their individual experience and join the dot to build a story and a narrative that finally can be heard, maybe. So Qassandra, maybe you want to explain to us about what is that tool?
Yes, we had a lot back and forth between regarding that tool, between if we want to create something for patients, for to give him power in some difficult situation in healthcare, or to raise awareness for professionals of the healthcare that they have a responsibility to think about the biases, the prejudices, and stereotypes. And we quickly decide to address this tool to professionals because there is a lot of authors who have observed that the consequences of racism among patients, among people who are from the immigration first or second generation, or even the third. So for us, it was because we are an association of psychologists and professionals of the healthcare, it was very important for us to say to our colleague and to the medical people that they have responsibilities to stop believing that there is an unconditional acceptance of everyone in the different states of healthcare. That's not true. We know it today. We see it every day. We heard of it every day, more now than 10 years ago or 20 years ago. But we now know the consequences for those communities. And it was for us some kind of alarm system to say, you are doctors, you are nurses, you are psychologists, psychoanalysts, you cannot afford yourself to be in the denial that what you aware about your own biases and prejudice have consequences, real consequences for the people you receive, for the care you give. So it was something that the barometer was for us a first draft. A first draft that was a bit of a lot of experience, our own experiences, the experiences of the member of families. And we ask also our patients to share with us anonymously what they encounters in the healthcare, in the how they were treated sometimes, the things that they think that was not problematic and now they see it's problematic, and the things they think it was problematic but they can now see with some kind of nuance.
I think what you had, sorry for butting in, but
yes.
Time's ticking, isn't it? But I think what you have on the rhesus meter, if I've said that correctly, is very similar to what we've got in PCREFT, the Patient Carer Race Equality Framework. And it'd be really good for us to sit down and look at what the models are in France, what you've developed there, to what's been developed in this country, the PCREF, that's underpinning the patient and carer race elements of care in this country. It would be really good to kind of see if they do marry up at all.
Indeed, Julie, you're right. We're out of time. So I think there's a lot we can discuss, and we'll probably have a further conversation and sessions about all of this, because if one thing I'd remember from our conversation is that this issue is a lot bigger than it seems at first, and probably a lot more complicated. So I'm excited that we've kicked off that conversation. I don't think by any means we're closing it today. But before we say goodbye, I'd like to ask every one of you to say one thing you'd remember from our conversation today.
Okay, I'll go first. One thing, culture.
Good. Who's next? Thank you, Julie.
I'll jump in next. I'll just say that given what we have with Compass, with what Qatar is doing, and like I said, there are these health systems in different countries. There are many different programs looking to improve it. I think the WHIS platform is the place that's going to happen. This is where we can really make that happen. That's one thing I would like to say.
Cool. Qatar?
Well, I can go next. There is a lot saying just one thing. I'm very excited by what we opened today. Really, really, really excited, because I think that we said earlier how we can maybe try to really take this issue of racism en charge. For me, it's very like those kind of meeting, of discussion that will give us power to create something that can be related to everyone, and maybe not leave people alone in this violence of racism.
Thank you.
And just a final point from me. Yeah. So I think have courage, be courageous to address this wicked issue. Don't shy away from the conversation. That's the starting point. Let's be open and honest, and let's face it together. Because without doing that, without recognition, without acknowledging unconscious bias, then we just can't get started. So we need to be courageous.
Fantastic. Well, I think the next session will be for 2 hours, maybe. I've got a lot to say. We all have.
We want to hear it. We want to hear it.
Absolutely. And we want to give our audience the opportunity to be able to fulfill the reasons for coming onto this platform and to put stuff in the chat so that we can all learn from each other. Absolutely.
Thank you all so much for joining today. I also want to thank Keisha Green, who is not with us, but she really helped in the preparation, and it was important to hear her story today.
Yeah.
Thank you all. Have a great day. Share your comments, questions, all of it.
Bye-bye.